Next, we will hear from Katie Eyes, Vice President, Program and Strategy at Blue Cross and Blue Shield of North Carolina Foundation. Katie works closely with the program team, grantees, and others to support communities in North Carolina to look upstream and transform practice and culture to dramatically improve health. In addition, she provides leadership for the foundation's focus on oral health. We're so grateful she is with us today to share her team's efforts and partnerships to support oral health in North Carolina. Katie?
Thank you, and appreciate both of you for that great setup. I will take a little bit of a different approach. As Catherine said, we're a statewide funder. We're focused on systems change, and I was asked specifically to share about our school-based oral health work. But I also want to contextualize that to some degree. And I'll start with the assumption that some in the audience are looking for strategies to increase access to care locally or at a larger scale. Next slide, I'll appreciate the sort of orientation to the science and data and bring in a little bit more qualitative with this quote. And it's really observations like this that highlight what a moral challenge this is that was alluded to. How much inequity is baked into the way we frame up and address oral health. And in particular, this notion of the slow motion catastrophe really resonates with me. These are poor oral health outcomes, the indentulism, opioid prescriptions, ED visits that Dr. Chalmers described are really part of a longer trajectory of chronic disease. And, you know, the layperson, which is what I am, have been socialized to think about oral health really episodically, but it's a chronic disease, and it's our belief that school-based models can really be a part of acknowledging and addressing that. Based on their care models, they meet children and families where they are and create an environment where they can take a much more patient-centered approach and preventive approach to oral health care. A little bit about North Carolina, and the data that Dr. Chalmers shared shows us we're not unique here, but we do see significant equities. We know that preventive care is cost effective, but it's not accessible to those who are at the highest risk in significant parts of our state. And that's because of cost and access barriers, including workforce. And so those conditions really have led us as a foundation to focus on workforce policy and financing in our strategies around oral health. And I hope that by the end of this sort of talk, you'll share some of the understanding about how school-based work is a part of that. Moving on to the emerging context slide around COVID. In the questions I saw submitted with registrations, really saw some interest in the impact of COVID. And again, Dr. Chalmers mentioned some of this, but generally it's really fast-tracked some innovations here in our state and lots of interest in teledentistry and minimally invasive care. It's created some new incentives for the dental profession to move towards prevention-centric approaches. And those are some of the same approaches that really prevent disease, preserve tooth structure, and contribute to value, and are really easily applied in the school-based setting. I'll just also add, I don't think this was mentioned, it's really contributed to staffing shortages, and we see that in the safety net in private practice. And then this piece around foregone care, certainly in schools, we are beginning to see the effects of that. What types of disease progression happened in the last 18 months of relative isolation when people weren't seeking care. And we're also seeing supply chain issues impacting some of our school-based programs as well. But the bottom line is really that the impacts on the oral health system during the pandemic have been disruptive. We think we'll see greater inequities and worse oral health, and that some of that disruption could lead to innovation that has an important impact. So on the next slide, I'll sort of move into our school-based oral health work and the models that we're supporting. And this is one of 3 strategies that we use in our oral health focus at the foundation, really supporting the spread of these models across the state. And I'll say this is not the first approach we used when we started out funding oral health about 10 years ago, but really builds on our experience and learning over time and the relationships and momentum that has been built in the state. We are trying to do this at a pretty significant scale We have 3 funders in 2 states and 2 dental schools, in addition to all of the clinics and communities involved, but it's something that can be replicated at a local level and really sort of builds on our experience that these programs have to be sustainable and must be dental homes. But again, no reason it can't be done at a smaller scale. And so you'll see on that slide the program goals we have. It really is about creating access to oral health care in a setting where children spend much of their time in the schools. And we believe this has the potential to address many of the barriers to oral health access that exist in communities today. The partnership, then you'll see it's the Duke Endowment, the Blue Cross Blue Shield of South Carolina Foundation, and our Blue Cross Blue Shield of North Carolina Foundation. We've been working on this together since 2019. Just technically, it starts with 6-month readiness grants that we actually have a grant opportunity open right now for a 4th cohort of these grantees. Those are $65,000, and then we go into a couple of years of implementation funding that supports sort of the startup costs of these new programs. We provide technical assistance throughout the initiative, and we've sort of created the opportunity to fund up to 10 programs a year from both states. And the programs really vary based on the community's needs and the assets there, but the model really requires kids being seen in schools to have a dental home that will ensure that their treatment needs are addressed either by a dentist who is visiting the school or by a referral to a fixed site. And that requires a lot of partnership between the school system, teachers, administrators, the clinic staff, the navigators who work with families, and then as well as the families and kids themselves that are essential to making that work. And as I said, each implementation is different, but all of the programs emphasize prevention and less invasive care as part of their comprehensive care models, in part due to their setting and the opportunity to focus more so on prevention. On the next slide, you can see the locations of the schools served by the first 3 clinics, and each color represents a year, with orange being the first cohort of grantees. And so those are the locations of the schools. There's some COVID-related hiccups, as I said, related to supply chain and whether schools are allowing sort of outside providers into the school setting this year. But this is sort of largely what we expect to see when things settle. There are all sorts of models, as I said. Some of them are buses that pull up to a school and see the kids in the bus. Some of them, vans. A lot of them are portable equipment that gets brought into the school. And this is not only about seeding these models, but it really also engages the organizational and clinical leaders, as well as the school leaders, who want to do things differently in their communities. And they have really become champions for this work and the policy changes that support it. In terms of coverage, if you're familiar with the geography of North Carolina, you'll see we're in some rural areas, but perhaps not not necessarily the ones where the access barriers are greatest or the outcomes are the most challenging. And so in this 4th and 5th cohort that we're recruiting for now, we're doing some pre-readiness coaching, and we identified 20 high priority counties where we really want to seed some of these programs over the course of the next few years. On the next slide, you can see the focus on TA has been significant, in part because we are doing this at scale. And so it's led us to focus on all of the aspects of the planning that are required for success. And it's a screenshot of an article from Maternal and Child Health that really focuses on the TA curriculum. The grantees in these cohorts receive peer support from each other, which is really critical, and technical assistance led by a team led by Amy Martin at the Medical University of South Carolina, and also supported by East Carolina University School of Dental Medicine. And that technical assistance covers many topics, starting with site selection, service scope, how to use electronic records in this environment, the different staffing models, how to develop partnerships, billing, consent, and case management and navigation. But I would say that, a significant piece is what the cohort learns from each other and the peers. Some of the stories I've heard from these sites, where you want to install the electrical at the school so you can plug in your van or your bus and warm it up before the school doors open. Not parking your vehicle to unload your chairs and other equipment on the athletic fields in the mud. These are the real life lessons that peers bring to each other that really influence the success of a program on the ground level and have also proved invaluable. On the next slide, you'll see a sort of deeper screenshot into the components of the technical assistance. And again, there's a substantial planning period for these grants. And during that period, really focusing on a care management plan, a business plan, a community engagement plan for those so that will be successful in all domains and really achieve the impact and the sustainability. That TA is offered by pre-recorded webinars, live webinars and convenings, and individual coaching to the grantees so that they can apply what they're learning. And then we've also built in this a lot of peer connections so that people are visiting each other and the programs in the state to see what's happening on the ground in different sort of manifestations of the program. And that networking among the safety net dentists and administrators has gotten a lot more robust over time and gives sort of common ground to innovate beyond the school-based work as well. On the next slide, I wish I could show you a video, but we've got a screenshot of Dr. Francisco Rios, who's at Kinston Community Health Center, to sort of show what this looks like in action. All of these sites really offer full scope care that can include a referral and navigation to a fixed site when it's needed, but Dr. Rios visits the school and does most of the services on site at the schools. That's exam, radiographs, cleaning, varnish, restorations, and most of the sites do use silver diamine fluoride as well. The care managers and navigators are a critical part of this work to liaise with the schools and families. And you can really sort of see from his quote how much of a passion this has become. This clinic was in our first cohort, and they're working in 13 schools. They're a community health center working in 13 schools in their county. And when they go out, they see about 25 students a day, and they're working their way through the prevention, treatment, and referral as needed. I mentioned that, this sort of leads to other work, and a school-based center in the Mountain West, I heard from one of their dentists recently, and during the course of their work in the school base, they've also grown a lot at their fixed site. They went from one dentist, and now they have more than 3 FTE dentists. They've added 3 operatories to their clinic. They've added nitrous. They've upfitted a mobile unit. They're increasing their sort of sealants first focus in the fixed clinic, and their use of silver diamine fluoride. And of course, that's not all attributable to this work, but it reflects, I think, the leadership that these folks are bringing, as well as the sort of desire to learn, innovate, and expand their services that really has served them well in developing these programs and applying them elsewhere. And I'll say it's a big success measure to us that most of these sites are using a recent rule change around public health hygienists in their school-based settings. And North Carolina was, until recently, one of only 4 states that really didn't allow hygienists to deliver any preventive services without a prior exam by a dentist. That changed to a limited degree in 2020, and it was one of the really first Substantive Practice Act changes in our state in more than a decade. But many of these sites are sort of jumped immediately into using it. So it's really sort of a connection to our policy work. The grantees are contributing to advocacy for that policy change, but they're also providing experience and models that show what it looks like on the ground when it's being used. And that lowers the perceived barriers to others to see that model in action. And so it really provides not only feedback loops to the future policy agenda, but reinforces any changes that we make in the policy environment as well. And so that'll lead on the next slide into sort of the snapshot of our policy change strategy. And just want to reinforce that strong connection between the school-based programs and our strategies to advance payment and policy change. So we support a coalition working to that, and the schools really serve as a proving ground and a platform for scaling and helping to identify what other policy changes are needed. Those new programs not only create the access points, but also a shared understanding among families and dentists and hygienists and advocates about what practices and policy changes are needed and what's working to reduce those barriers to care, and they become a part of that network of advocates. And so on the next slide, just some screenshots of different articles, publications that have come out recently. And, really appreciate the data that Dr. Chalmers shared, and we'll just underline that data has been really critical to this initiative as well, of both data transparency at the state level, and we're not yet at a point where we can see the impact of these programs reflected in our data, but I do hope that'll come. But we do know that the data transparency among sites and the data transparency or use of data within the individual implementations has really contributed to sort of growth and technical assistance and coaching and change applications at the clinic level. So I'll just close with that learning from us around the importance of data and data transparency, and the fact that these school-based programs are really not working in isolation from our policy-focused work, but are an opportunity to build momentum and inform our larger change agenda. Back to you, Catherine.
Thank you, Katie, for sharing Blue Cross Blue Shield of North Carolina Foundation's leadership on oral health and these great efforts and takeaways for how we can improve access to care for school-age children.